Good morning, doctors. Good morning, doctors. Greetings from FDC Limited, the makers of Zocon. I'm Shailendra Meena and I welcome you all in this fine Sunday morning in this international symposium where we are going to discuss the common vulvovaginal infections and their treatment strategy, which is a very common infections, especially if you think of India. And we have with us the international faculty, Dr. Graeme Dennerstein, who is the authority in the field of vulvovaginal infections. He has worked extensively in this aspect and published books on the same. So this is an opportunity for Indian doctors also to collaborate internationally and form the guidelines which will benefit all the doctors all across the India. So without taking much time, I'll introduce the moderator for the session and hand over the session to him for further proceedings. Just let me share my slides. So our session is going to be moderated by Dr. Sameer Hazra, who is a well-known and one of the best doctors in eastern part of the India. He is CEO come medical administrator, senior obstetric and gynecologist with oncology come advisor for quality medical services and qualitist in a hospital of women, which he owns, which is a unit of RC Hazra Memorial Hospitals. He is trained in gynec microsurgery, gynec oncology, breast cancer surgery, gynec plastic repairs, keyhole surgery. He is also general and high risk obstetrics and gynecological surgery. He also do infertility with IVF support and endocrinology. He is a medical administrator, which is already mentioned. He is a lead auditor for ISO 9001-2008 certification, which is total quality management, and he is also internal auditor for NABH. He is a black belt 6 Sigma for health qualitist and healthcare management, and advanced finance advisor for latest hospital planning and logistics. He is also quality assessment and advices for quality medical care with perfection quality test. His list was way too long and I've compiled it in a short in one slide. So welcome Dr. Sameer, and I hand over the session to you, sir. Thank you. Over to you, sir.
Thank you very much, Dr. Minaji. And along with, at the outset, I just want to thank FDC for allowing us to have a common stage with Dr. Dennerstein from Australia. We are going to have a very nice meeting and a very nice sharing, because some doctors will be from India, eastern portion, some doctors, I am from eastern portion, Dr. Vaishali and Dr. Aruna Pujari will be from Mumbai. That too from two very extreme degree of patients group what we will be facing in our discussion phase. And along with us, we'll have a king of vulvovaginitis, or king of why I am calling him king, because he has done most of his research and publications in vulval and vaginal infections only, as well as I'm very proud to say that we'll be gliding on an airplane because he is a pilot also. So we are very happy to have him with us, and cutting short of most of the time because he has got a very huge list of achievements, but I'll try to brief it as minimum as possible. Like Dr. Graeme has been a graduate from Melbourne University and got initially trained as a general surgeon and changed to obstetrics and gynecology, achieving the top marks in MRCOG exams. Congratulations, sir, and you deserve it. He's private and public sectors. He has done researches and published many aspects of his specialty and also he has co-authored a book called The Vulva and Vagina Manual. He was the founding director of Dermo-Gynecological Clinic of University of Melbourne, Department of Obstetrics and Gynecology at the Mercy Hospital for Women. Graeme also completed his service in Royal Australian Air Force Reserve Medical Branch as a consultant gynecologist to the Director General of Air Force Health Services in the rank of Group Captain. And holding on a personal pilot license has enabled him to provide specialist outreach services to the rural hospital and work in aviation medicine also. Great, great job, sir, and you require a good clap for all those big achievements. As well as he currently practices from his Essendon rooms in office and surgical gynecological workup, including vulvovaginal sexual disorders, infertility and contraception, menopause, endometriosis, menstrual and continence disorders, as well as he is attached to the public hospital appointments also of Kerang District Hospital. Very nice to have him with us, and we are very proud to listen from his views, how we see our patient and how they see at Australia. Even though like we can say that there won't be much difference in presentation, but obviously there'll be a different touch in the approach, how they approach to our patients or to our dear mothers. So over to you, sir, and with a very nice like warm welcome from India, we welcome you, Dr. Graeme, and just share your valuables with us so that we can increase on our system also. Thank you, sir. Welcome to you, sir, Dr. Graeme. And
thank you very much.
Open to you.
Thank you very much for that flattering introduction, and good afternoon from Melbourne. So I'm to speak on to ascertain the place of fluconazole in the treatment of vulvovaginal candidiasis. Fluconazole, the introduction of fluconazole has been a significant advance in women's health. Candidiasis is the commonest disease of women because estrogen promotes the production of glycogen by the vagina, and Candida albicans thrives on glycogen. So, fluconazole. Next slide, please. Next slide. I use fluconazole in 3 clinical situations. Treatment of the acute episode, and I'll say it again, it's so important it is in conjunction with vaginal anti-candidal treatment. There is, but I'll speak more about that in a moment. Secondly, the long-term treatment to prevent recurrences when recurrent candidiasis has been diagnosed. And the third is for the treatment of the relatively uncommon condition, but an important condition, Candida albicans cutaneous mycosis. Next slide, please. So if a patient turns up with a classic case of candidiasis with vulvitis and a red vagina with thrush spots like this for the first time, it is probably reasonable to treat it without laboratory confirmation, but laboratory confirmation or microscopic confirmation is essential if it recurs. Next slide, please. So if the initial acute episode, as I've just shown, is correctly treated, it does reduce the risk of recurrences. There is no doubt about that. I've been practicing long enough to know what candidiasis does, because I remember what we were up against before azoles like fluconazole were introduced. So what is the proper treatment of an acute episode like I have just shown? A statin dose of fluconazole, that is a 150 milligram tablet, just the one, but I believe it's essential that vaginal treatment is used as well. There is a bit of a tendency to use fluconazole alone because it does work in many of the cases, but recurrent candidiasis is a big problem, which I'll discuss shortly, and it is essential that measures are taken to prevent it. So in addition to the statin dose of fluconazole, the best is 6 days of 1% clotrimazole vaginally, 6 days of vaginal clotrimazole, or if the patient is sensitive to topical steroids, and many women are, then the gentle alternative is nystatin, which is a much less irritating topical preparation. 100,000 units in 5 grams vaginally, but it has to be used for 14 days. It takes longer to eradicate the yeast than clotrimazole. So let's pass on to recurrent candidiasis. Next slide, please. Thank you. If the patient returns with genital discomfort and candidiasis is suspected more than once, it is absolutely essential that confirmation of the diagnosis is performed. I am convinced now that the empirical and inappropriate management of candidiasis is probably the commonest cause of so-called vulvodynia, a term which, I must be honest with you, I consider the refuge of the diagnostically destitute. So if you do confirm that Candida albicans has recurred in spite of the treatment, which I showed in the first treatment slide, within 6 to 12 months. I'm sorry, go back. Within 6 to 12 months, then you're dealing with recurrent candidiasis. And just beware that occasionally recurrent candidiasis can be a manifestation of an underlying disease, diabetes mellitus being number one, but immune deficiency disorders and disorders which result in the use of antibiotics, because antibiotics are yeast growth promoters, are common underlying conditions that can contribute to the patient being diagnosed with recurrent candidiasis. And once they have more than 1 or 2 episodes, then they get all the other problems that go with recurrent candidiasis, particularly sexual disorders, arousal failure, and secondary vaginismus. And it's probably the commonest cause of so-called vestibulitis syndrome. So let's just say a little bit more about confirmation of diagnosis. Next slide. The high vaginal swab is the gold standard and can be assumed to be 100% accurate. But beware, false negatives will be obtained if the patient has self-treated within a week or 2 prior to taking the swab. So it's essential you inquire if the patient has self-treated. My own personal preference, because I've been using it as a diagnostic technique actually for over 50 years, is the stained vaginal smear. I'm a great advocate of do-it-yourself vaginal cytology if you see a lot of these patients. It's not quite as sensitive as culture, but done correctly, it is 85% accurate. And the third technique is the microscopic examination of a wet mount. That has got variable accuracy. It's probably over 50% sensitive, but it's not really in the same league as culture and stained smears. So, next slide. Next slide, please. A simple technique of do-it-yourself cytology is described in the Vulva and Vagina Manual. Next slide. Next slide. I use a cytology brush and separate the labia and insert the cytology brush the length of the vagina. Next slide. Smear it on a clean slide, as one does with the cytology, the old pap smears. Next slide. Spray it with cytology fixative. Next slide. 10 drops of right stain left for 1 minute, 60 seconds, and then a double volume, next slide now. That's the right stain. Water, which needs to be pH 7. Most tap water is suitable, but you've just got to be a little bit careful and check your tap water if that's what you're going to use. And that's left for about roughly another 2 minutes. The slide is then blotted dry. I use one of my wife's old hair dryers to hurry up the drying process, and it can be examined with immersion oil and a cover slip, or preferably mounted with proper adhesive and a cover slip. Next slide. And this is what you see. This is one of my right stain smears, and you can see the filaments of Candida albicans. Candida albicans is a dimorphic yeast. That's its characteristic appearance. Filaments and spores, blastoconidia. And here you can see the pseudohyphal filaments and its characteristic non-staining capsule. Incidentally, notice that there are no inflammatory cells, and most cases of clinical candidiasis are not actually a vaginitis, but the yeast gets stuck into the epithelial cells and their glycogen and produces irritating chemicals, including alcohol, incidentally, which comes out with the normal secretions and produces contact dermatitis of the vulva. So it's, in most cases, it's not correct to talk about candida vaginitis, rather simply Candida albicans infection. Next slide. And this is another example, and you can see the spores, the blastoconidia, as well as the pseudohyphae, the filaments. Next slide. So if you do have 2 proven cases like this within 6 to 12 months, then you're dealing with recurrent candidiasis, and further measures need to be taken. And as I have said previously, look for underlying pathology, particularly diabetes. But the management of the patient who has a recurrence is once again vaginal treatment and commencing fluconazole, and I use 100 milligram twice weekly for a minimum of a month, but I quite commonly use it up to 6 months. And as a general principle with candidiasis, the longer the patient is kept free of the condition, the less likely they are to ever have the condition again. Other treatments, incidentally, for recurrent candidiasis, unfortunately, fluconazole can't be used in pregnancy because it has not yet been shown to be safe in pregnancy. And if I diagnose recurrent candidiasis in a pregnant woman, I get her to use a nystatin pessary daily until she delivers. And the other technique of reducing recurrences, where possible, is to reduce vaginal estrogenization. That means a change of contraception to my preference to progestogen only injectable, the best of which is still, in my opinion, DMPA, depomedroxyprogesterone acetate, marketed as Depo-Provera or Depo-Relavera. And if the patient is on hormone replacement, menopausal hormone treatment, reducing the dosage. Next slide, please. This is what I call the candidiasis line. This is the serum estradiol, above which candidiasis is common, below which candidiasis does not occur, unless, as I said, the patient is diabetic or has another immune deficiency. And so this is why we don't see candidiasis before puberty, although you can get it in infants who still have their mother's estrogen on board, and why left to nature, it is worst after ovulation when the serum estradiol peaks, and it is fairly common on the oral contraceptive pill, but the modern oral contraceptive pills are no worse than the natural cycle. Pregnancy, with its very high serum estradiol, is the commonest setting for recurrent candidiasis. And it is important for obstetricians to take it seriously, because not only will the pregnant woman be distressed, but candidiasis can be a big problem in the neonate. Lactation turns off the ovaries if it's in most women, if they are fully breastfeeding, and candidiasis is virtually never seen in lactating women. As I've said, depomedroxyprogesterone acetate gets the patient below the candidiasis line, and candidiasis should not be diagnosed, certainly without confirmation, in the postmenopausal woman. It can be the first manifestation for diabetes, but hormone replacement is the controllable situation. Next slide. The third setting I wish to discuss, for which fluconazole has been an enormous advance, is Candida albicans cutaneous mycosis. This can be a difficult diagnosis to make. Most of the cases I've seen have presented with skin disorders of the vulva, which have not responded to topical steroids as I would expect them to. To diagnose a cutaneous mycosis requires either a biopsy or skin scrapings taken with a scalpel blade and sent for culture. And very important that if they do grow a yeast, that it is speciated. Next slide. Next slide, please. This is what a biopsy stained with PAS stain looks like. And the pseudo-hyphae of Candida albicans are absolutely obvious on a PAS stain. However, next slide, please. Next slide. If the pathologist only uses hematoxylin and eosin, H&E, a cutaneous mycosis can be missed. This is the same patient that you have just seen, and this is H&E staining of her biopsy. You can just make out the pseudo-hyphae of Candida albicans where the arrows are pointing, but you can see how easily the diagnosis can be missed. So just keep an eye on your pathologist that they're staining your biopsies with PAS. So what is the treatment of cutaneous mycosis? Thank you, next slide. The treatment is fluconazole, 100 milligram daily, and it has to be for a minimum of 1 month, because that's how long it takes for the fluconazole to get from the basal layer up to the surface. It's roughly a month skin turnover time from maturation from the basal layer to the surface. So they're the three situations and their treatment in which I use fluconazole for Candida albicans treatment. Next slide. I just want to mention other mycoses which keep gynecologists in business, and they're worth mentioning in this context because most of them are relatively resistant to all azoles, including fluconazole. Particularly dermatophytes, the cause of tinea cruris and pityriasis versicolor, which are usually trichophyton species, including Malassezia and Trichosporum. These are the dermatophytes, and unfortunately they're azole resistant as a rule. And non-albicans yeasts, which fortunately are usually not pathogenic and therefore seldom need treatment, and they tend to be azole resistant too. So just a few words before I finish on fluconazole resistance. Fortunately, it is so far uncommon, at least in Australia. But like any antimicrobial, particularly if it's used inappropriately or abused, there is a risk of organisms becoming resistant to it. I have had one confirmed case. So if I don't get the response to fluconazole that I expect, I get my pathologist to, when they culture Candida albicans, to test it for fluconazole sensitivity. And this is just something to keep in your mind if you don't get the response to treatment that you can that you expect. Thank you very much. So I'm available for questions.
Samir, yeah.
I'm really happy that we got so nice insights, the way you all see patients there at Australia as well as major universities throughout the world. And in India, I mean, I don't know how many of us, apart from dermatology, especially dermatologists, they're more keen on getting those biopsies done. But a very important note, what you rightly put up is estrogen is one of the most positive factors for our vulvovaginal or candidal infection. Secondly, that is why, as rightly what you have put up, this is a very good important carry-on message whenever we are giving OC pills as well as things. We should see that whether we choose it, because depending on the patient's age as well as with obesity as well as texture of skin, so many factors we assess before giving a OC pills, or we should assess that estrogen itself may be one of the causes for your vulval infection as well as candidal infection. A very nice, well said picture, sir. And moving ahead with it, I just want to see whether any questions are there so that we can, for Dr. Stein, there is one very nice question asked by Dr. Vipra Pandey from Uttar Pradesh. The role of nugget scoring in diagnosis vaginal infection. How do you go ahead with it, sir?
I'm sorry, with what rule?
With nugget scoring, NUGET, nugget scoring.
Oh, Nugent scoring. I must admit, I really find the need for it. It's either a diagnosis or it isn't.
Diagnostic tool, basically, there were 6 criteria. Few microbiology criteria, there are few clinical symptoms are there. It's a very old technique, but we don't use it right now. We just goes for the clinical thing right now. So there's not much in it. So especially out of 10 scores are there. In that, out of 7 score is a good finding to say that, okay, fine, the patient is having a recurrent disease. And it is again, the scoring depends on microbiologist. And basically, it is for bacterial vaginosis. And it is done by pH, and it's lactobacillus thing. Any other questions which is related to Dr. Riyab? I would just like to ask, like, some person, I think that will take it a little later. But what are the causes of recurrent vaginal infections? Sir, would you like to add any more thing on the causes of recurrent vaginal infection?
On which, with what organism?
Yeah. Any organism. What are the recurrent causes, basically?
Well, it's yeast, Candida albicans is undoubtedly number one. But I don't think I've got time to discuss other subjects like bacterial vaginosis.
You can lead on that only, but like basically again, Candida is one of the most common causes for recurrent vaginal infection, also untreated or quarterly treated or half treated or quack. In India, we find a lot of quacks, they treat half-heartedly. Those are the major causes in India as far as recurrent vaginal infections are concerned. One more very nice question has been there. I mean, I just want your views on it. Why fluconazole is safer than itraconazole? It's a pharmaceutical question, but would you like to answer that question, sir?
Well, it has just been, of all the azoles, it has the lowest incidence of hepatic and general side effects, which have been a bit of problem with the earlier azoles. And this is why fluconazole has been such an advance, because of its relative safety.
Yeah, I think that's in. We should give one more question from Dr. Aruna. Please unmute you, ma'am. Yeah.
So I wanted to just comment on the previous question with your permission, please, and with Dr. Graham's permission. May I please comment on the previous question? So another important aspect of fluconazole and itraconazole is that the absorption of itraconazole is very, very erratic, and it can be very different in different individuals, whereas with fluconazole the absorption is pretty good and sturdy amongst people, whereas itra otherwise is very erratic in its absorption. So
yes, I would agree with that.
Especially then, that is why in itraconazole cannot be given in aged older patients and vulnerable to hepatic as well as renal dysfunctions and all these things.
yes,
Mostly that means what it brings to us to one thing, like if we want to give itraconazole, we need to get a hepatic function test as well as renal function test also, and that comes a lot to a patient from pocket, because in India we don't have much of insurance system to pay the medical bills. It's the patient who needs to pay.
I must say I have never seen any hepatic problems with fluconazole, but I have heard of them with the earlier azoles.
Other advanced secnidazole or itraconazole, gynoterazole, so many other modifications have come of azole groups. So just giving little rest to Dr. Graeme, and I wish he stays with us. We can go ahead with the case discussion right now, because we are running little sort of time too, because most of it today is a Sunday. I think I don't know whether Dr. Vaishali Joshi is in OPD or not.
No, sir, but I have some other something scheduled. But yeah, that's fine, sir. That's okay.
So without losing much time, I think we will go to case discussion. So first thing, I just wish Dr. Vaishali takes the lead and opens her own ear. To introduce Dr. Vaishali, I don't know how big list may be, so I have requested her to make it a little short with FRCOG, and she has done MD. A huge applause for her FRCOG, DNB as well as DGO, FC. I think she doesn't miss any degrees available in India, in the world right now. European diploma in gynae endoscopy, BSCCP accredited CCT, a very well-known gynecologist and obstetrician, and a full-time consultant, Kokilaben Ambani Hospital. She has been receiving the Adi Dastur Gold Medal as very coveted award from FOGSI, BCCP accreditation for the diagnostic and therapeutic modules by July 11th, she got it. And after getting her fellowship from obstetrics and gynecologist in 2017, she has written umpteen number of papers, international as well as national papers, and she has given so many patients educative program, and we are really blessed to have her with us. And just to open up, I just wish her to open the case presentation. She has the first case. Over to you, Dr. Vaishali, ma'am, please.
Thank you for your kind introduction, Dr. Samir. So can we have a next slide? Sir, my first case is, can we go to the cases, please? Yeah. So this is a 35-year-old, a para-2, who had normal vaginal deliveries, presented to my OPD with a perineal discomfort and painful intercourse, along with itching of the perineum, which has been very recent. She gave a history of yeast infection, which was self-diagnosed and treated by herself by OTC medicines after consulting a friend who had similar problems, and she had a cure from that. Her current mode of contraception is birth control pills. There are no other risk factors like particularly diabetes or a recent ingestion of antibiotics in last 2 months. Next slide, please. So on local examination, you saw in the previous slide, as you can, if you can go back, sorry, on the labia majora, on the right side, there is a inflammation, there were scratch marks, and if you can just a little bit enlarge the image on the right labia majora, where the arrow is, there is a small 3 to 5 millimeter area showing a warty growth, mostly a genital wart. So if we can go back on the slides again. And the next slide after this. Okay, so on a local examination, these were the findings. On a per speculum examination, there was curdy white discharge attached to the lateral vaginal walls. The cervix looked healthy. There were no signs of cervicitis or any ectropion. And on bimanual examination, there was no phalangeal tenderness and the uterus was normal size. There were no warts also seen on the vaginal walls or on the cervix. So this was a presentation. The main thing is, how do we proceed from here? Because first thing, we have established that this patient has come with the typical signs of vulvovaginal candidiasis. Obviously, this is a clinical diagnosis. We have to confirm it with the investigations, and where I think Dr. Aruna comes into play. I would ask Dr. Aruna what will be in the clinical setup. How do you think will be the best thing to approach for a quick diagnosis? Because as you know, almost there has been a recent paper published in a cohort study which shows that the visual diagnosis is hardly 10 to 15% correct. So one has to back up with the investigative methods. So over to you, Dr. Aruna.
Yeah, thank you very much, Dr. Vaishali. Now I just explain Dr. Sailenderji just to highlight Dr. Pujari's, just next, Now we are again blessed to have another stalwart in the field of microbiology, Dr. Aruna Pujari. She is a epitome and she is a walking microbiologist with a huge talent. And presently she is attached to Brish Candy Hospital, Mumbai, as a head of department of pathology and microbiology. We need not look at her qualifications because she has done all the qualifications available in India and UK, starting from MD, DNB, diploma in HIC as well as CIC, diploma in infectious diseases, diploma in from UK, and she has written 38 international books and reviewed publications. A great applause for that, ma'am. You're a monument in this thing, and we are really blessed to have you. And as far as teaching experience is concerned, she has been a DNB teacher. She has been a lecturer for CPS and for Mumbai University. She has been a PG teacher from MSc Microbiology, as well as she has delivered more than 140 guest lectures throughout India along with infective controls. And as far as microbiology is concerned, I think we are happy to have him, and Brish Candy as well as Mumbai people are very lucky to have him as his conceptor. And most interestingly, we see her notice of my interest also. She's more concerned about hospital infection control as well as quality management in lab and teaching, and which I like most. So over to you, Dr. Pujari. Now, how we are going to go ahead with all these things? Because again, I'm going to come out with another 3 cases.
So thank you for that kind introduction, and thank you FDC for giving me an opportunity to be here. So as Dr. Joshi pointed out, and earlier Dr. Graeme pointed out, I think just looking at the gross examination cannot be the only way to go about diagnosing vulvovaginal infections. Now, this picture is so clear cut that, and there's so much of material that is available that can be tested, that one should not miss an opportunity to test this material. So this patient has had a previous episode of query candidiasis in the past, for which she had self-treated herself. There's a nice white discharge that's available. Please collect this discharge, preferably if it can be taken in a cytology brush, or if it can be taken in using a rayon or a dacron swab, it will be better rather than the cotton swabs which we commonly use. And if it is sent in that way to the laboratory, we go ahead with doing a smear, a KOH mount, a culture, which is very, very important, particularly in Indian scenarios where we see a lot of non-albicans candida. And as Dr. Graham's PPT pointed out, these can also be resistant to fluconazole. So apart from culturing candida, we could also culture other organisms. The wet mount could be looked at, to see whether any other organisms are persisting. So I think those are the investigations in the laboratory that we could support with for this particular case.
Yeah, again, going to the slide, sir. So can I have my first case now? Yeah. So this lady which we see, she came to our OPD with a burning urination, itching vagina, and occasionally dirty vaginal discharge. Vitals on examination, vitals was normal. On inspection of skin, we saw both fungal. We can show you the scabies, ringworms are there. So many things were there. Next case, please. And these are the finding. On history, we see the patient was type 2 diabetes. She was on metformin and glimepiride, but was well under control. On inspection, we saw maculopapular crops, white discharge on her vagina. Per speculum, we saw the typical, you can see in this area, the like curdy discharge. Blood test shows normal differential count as well as total count, which is quite surprising. Means it has entered mostly into a chronic phase. And urine, routine urine also shows just few RBCs and pus cells. Because being a like gynae oncologist, I've got like what to say, a very urgency to do each and every patient for pap smear as well as for colposcopy. What rightly Dr. Dennerstein has mentioned, or as well Dr. Aruna Pujari, we should do cytology examinations. And what we can like every day I do more than 200 plus pap smears. And in that, mostly we find all these things. What rightly sir has elicited, as well as Dr. Aruna ma'am has also suggested. Next slide, please. So differential diagnosis. Again, can we have the other cases also, so that we'll, yeah. Now case 3, this is a middle-aged girl, 28 years, with 48 kgs, reported to our OPD with itching and discharge with typical burning micturition. No history of fever, no any suggestion of exposure or sexual abuse or abnormal sexual practice. Vitals were within normal limit. On history, we found a warty growth in the labial area and in a clitoral base also, as well as in fourchette. The cervical erosion was present. Can we just raise this portion a little bit? Or rather, we can see that it's a mixed type of infection is also seen. Blood test shows increased leukocytosis as with normal differential count. Urine routine shows few RBCs with pus cells. Pap smear shows infective cytology. Again, next slide, please. Next slide. Questions. Again, another extreme. This is a 13 years old girl comes to our OPD with burning vagina, with white discharge per vagina. Can't study because of this itching and getting irritable. Her school grades were coming, but it was falling. It was very disturbing for the parents because they didn't understand why she was not doing well with the school. Next slide, please. And she had menarche 1 month back, and after so much of picturization by our Akshay Khanna and all those pads and all these things, still we find very depressing to see our small girls using, or they're being trained to use clothes, and which is very not only unhygienic, but it is very, I don't know how they clean it also. Even though we abuse them, but still, whenever every day when we see their daughters come up, their mother has got a hot treatment from me, but when their daughter comes, we see they're still using the same pad, using cotton pads and all these things, and not the sanitary pad what it is prescribed. Again, when we saw her blood, she was anemic, leukocytosis was there, as well as lymphocytosis was found in this patient. Routine urine shows pus cells and epithelial cells, 4 to 5 in hypophil with albuminuria and no sugar. Next slide, sir. So now closing our patients, I think we are trying to show you all the 3 ages: menarcheal, premenopausal, as well as our, like here we see most of us always will see patient with discharge, patient with pain, urodyna, even with intercourse, they'll have painful intercourse. So many things they come. And we need to assess patient. Now, I think I want Dr. like Vaishali ma'am to add little more if she wants to add. Like these are the common things in our OPD, in our gynae OPD. Generally, we get more than 60% patients with these findings. How do you suggest, ma'am? And how do you see that in Mumbai?
Yeah. So Dr. Sameer, so looking at the variety of cases which we have seen just now, to begin with, the initial first case was also a mixed infection, I would say, with more likelihood of vulvovaginal candidiasis with a HPV infection. So what I would do in my practice, I'm blessed in working in a tertiary care unit where I have all the facilities available for a very well-known microbiology lab where I can do culture. Reports also are available on time. I have my dermatology clinic colleagues as well, where if I'm in doubt, I can always take their valuable opinion, because what I feel, vulva is a part of a skin. Obviously, vagina is specialized for us gynecologists, but these are overlapping things. So there is no harm taking valuable input and make sure that patient is treated and cured properly. As you were saying about the other patients, so from the differential diagnosis point of view, I told you about the first patient. The second patient looks like she is 45-year-old. She probably has multiple skin mycosis, maybe candida, maybe tinea. Along with that, she also has the kind of discharge it is looking, it's along with that probably candida, which we will do with the wet mount or the pH test. And probably she also has a urine infection because of the RBCs and things. So this is like we are looking at a complicated vaginal infections. So which needs to be treated with the priority wise sugar control, and then urine infection. If we treat her with the antibiotics, which is again going to give her a second episode of a future candidiasis. So all these things we need to keep in mind when we approach treatment of this second patient. The third patient, which can we go on the third case, the case after this, the 28-year-old lady with itching, burning in the urine. So this kind of symptoms itself tell us that maybe more likely either we are looking at infective pathology and with the florid genital warts. So on this, so this is also a mixed infection with a multiple of bacterial plus viral. So essential for us, for her to have a pap smear done along with the high vaginal swabs, and obviously we need to have a backup from our microbiologist to help us to treat the diagnosis. Now coming to the 13-year-old girl, sir. 13-year-old girl, I think she more likelihood that it is going to be this ringworms or pinworms infections, but we cannot presume, nowadays with the pandemic going on and things, and we have to look at the other aspect like child sexual abuse, any trauma, all those kind of things also we need to take into consideration when we approach any patient like her. And you have raised a very, very essential social issue that the menstrual hygiene, the perineal hygiene, these are the things we need to address right at this age. And not only we should educate the girl herself, but a family along with the father. That's what we really need to do, which will make a drastic change in our cultural practices and in society. So that's what I would go about, sir. Being frank with you, sir, if a patient comes to me in a clinical setup, they just want treatment. Diagnosis, if I take a meaning, when I came back from, I hope we have time, if I can just talk for 2 minutes, that when I came back from UK and started practicing in Mumbai, the first thing I was taking is high vaginal swabs, chlamydia swabs and things. But then the patients, even in a tertiary setup like us, the patient don't want to come and follow up for that report to come. They want immediate treatment. So I completely agree with Graeme that the clinical practice of maybe weight mount or at least a basic litmus test or gram, that will help drastically. The other thing is when we give up, all the guidelines say the treatment should be for 5 to 7 days. How many patients are compliant enough to complete the treatment? The minute they get better, they just forget about it. And that is where the this insurgence of resistance with microbial agents, not only antifungal. I think Dr. Aruna will tell you. And the recent studies which have published, meaning there has been a paper from a study done in New Mumbai. That's a local area from here. So they have seen about 10 to 15% increase in non-candida albicans vulvovaginitis. So this is all because of that. And I think it is more coming up in our metro cities. So that's how we need to balance everything. So there are some, meaning I'm blessed with my setup, but not everybody who have logged in today, who are independent practitioner and are a visiting practitioner. So, and they also want to satisfy the patient. So then there comes the role of this integrated treatment, like a combination of different things. So even that has also actually killed the diagnostic aspect of any disease. At the same time, it has also given rise to future candidiasis or maybe increase in the resistance. So these are my thoughts about our cases today.
Thank you very much, ma'am. It's a very nice thought, but going ahead, not losing much time. We'll just finish up the clinical, then we'll just hand over to Dr. Aruna, ma'am. See, clinically, whenever we see this patient, generally, basically, we should have few things in our head. Are we treating a atrophic vaginitis? Are we treating a cervical polyp? Are we treating a contact dermatitis? Entamoeba histolytica, excessive desquamation of normal vaginal epithelium may also lead to all these things. Large cervical ectropions, lichen sclerosis, lichen simplex chronicus, vaginal adenosis, vaginal cancer, vaginal intraepithelial neoplasia, vaginal ulcers, and vaginitis, like skin infection. These all things should be always in our mind whenever we are getting a case with this. Keeping differential diagnosis and the diagnostic consider. I've separated it because whenever I give lecture on this, always I say that these are the diagnostic criteria consideration we should always keep. as far as when we keep our differential diagnosis, we see, like along with all these things, cervicitis, what rightly Dr. Vaishali has put it as child sexual abuse. It has to be kept in our mind. Sometimes whenever we are dealing with younger girls, we should always keep it. Cystitis, maybe non-bacterial, cytomegalovirus infection, foreign bodies in rectum also, they may lead to vaginitis, herpes simplex, pinworm, what rightly Dr. Vaishali has said, postpartum infections, rehabilitation for Paget's disease. Paget's disease is also another which happens in our ear. Paget's disease, Rectus disease, then Refsum disease. They all have a vulvitis and you have as a syndrome based. Salmonella infection, sexual assaults, urea plasma infection, urinary tract infections, as well as varicella zoster infection. These are the and we can keep on enumerating number of differential diagnoses, but we should keep all these things in our head. Going to the clinical aspect, first thing what I want to say is what generally as a clinician we should keep within our premises is to do a wet saline mount. Got it? It doesn't require much thing, only want to do drops of isotonic saline solution. Second thing is Whipps test. Whipps test is also very nice, what rightly Dr. Aruna ma'am will be highlighting more with 10% potassium hydroxide. Got it? Third is the vaginal pH. These are the three things what our gynecologists should have within their clinical area. Third thing, or what we should depend now, again, we are going back to Aruna madam's domain, like we should have a facility for gram staining or pepanicolon staining or shift staining or right staining, what rightly Dr. Gram Stein has said. These are the things we should do it. Or else, if you want to go a little higher, like when we are seeing a recurrent like infections and all, we should we should keep in our head about the nucleic acid amplification studies. These also should be done and kept in our head. Then only we can go ahead with the thing. Now, with all this background, I'll just wish Dr. Aruna to come and share us how we are going to go ahead, not in detail, but in with as a clinician, what things should lead us and what thing we should do minimum, so that we can serve our female patients more in a better way and in a judicious way. First thing is that don't give medicine just like that. And I now want to hear what from Aruna ma'am, like what she wants. Like she might have seen many of our gynecologists writing in and out fluconazole, because every now medical representative come to us, tells us something about fluconazole, we start writing without diagnosing. Like Candida gabrulata, they don't respond to fluconazole. If we write a patient with Candida gabrulata, they won't respond. Then they will come to our senior, because if I am a male gynecologist, for patient to come to us, they visit at least 10 to 12 coax, 10 to 12 female gynecologists, then they'll come to a male gynecologist. So when we get a patient, we get pure, fully maltreated or ill-treated patients. So we know that we have to treat it in a different way. Now over to Dr. Aruna ma'am.
May I make a quick comment, please?
Sure, sir, please.
Vaishali, did you go to the RCOG meeting in Cape Town a couple of years ago?
No, sir, no.
I presented a paper entitled "What Makes Vulvovaginal Disease Difficult to Treat?" It was an analysis of my last 100 referrals from other gynecologists. And by far the commonest cause of the problem was that there was more than one diagnosis. A lot of the patients had 3 or 4 diagnoses, but the majority of these difficult cases had more than one diagnosis. And this is what makes our area so difficult.
Yes, definitely.
Thank you very much, sir. It's very nice input. And now we'll just go ahead with Dr. Aruna ma'am, please.
So I think most of it has already been spoken about by Dr. Vaishali and Dr. So it's very important to have bedside procedures. Don't bank on the lab, because as Dr. Vaishali mentioned, people don't want to wait for us to keep doing investigations. Everything should come in very quickly to them. And in India, at least, patients really just want treatment, as she's already mentioned. So a pH test, a quick wet mount, a KOH mount, or a Graeme stain or a Papniclaw stain, as sir has mentioned, are very good bedside procedures, and they don't require too much of expertise. All of us have seen through the microscope, so these become very easy, good. But if there is recurrence, please take help of your microbiology laboratory, send samples both for smears as well as culture, and ensure that when they grow a pathogen, for example, Candida, then they should speciate, because speciation is extremely important. And Indian settings, I've already mentioned, non-albicans Candida are supposed to be more frequent as compared to Candida albicans. Even in our, I think we did it about almost 5 or 6 years ago, when our cases of samples that we received from infections, we had more of Candida tropicalis than Candida albicans. Of course, with tropicalis, there is not much of resistance to fluconazole, but resistance is emerging. And the other thing that needs to be known is there are a few species of Candida which are intrinsically resistant to fluconazole. One of them being Candida krusei. Candida glabrata is supposed to be dose-dependent resistance, so you need a higher dose of fluconazole to treat Candida glabrata, not the usual 150 milligrams. That syndromic approach both from the point of view of clinical diagnosis as well as from the point of view of laboratory diagnosis is very important. So you don't about bacterial vaginosis or the organisms causing bacterial vaginosis. Look at other organisms like ureaplasma, mycoplasma genitalium, which are emerging pathogens, STIs, and they're very difficult to diagnose. Cannot be diagnosed because they don't in the lab, because they don't grow easily. So we need to do molecular tests for such bugs, whether it's Candida or whether it is a parasite. So this would be part and parcel of a syndromic approach based laboratory diagnosis. And again, the laboratories now also have panels for syndromic approach diagnosis of STI. So if you have a laboratory that can support you on this in this way of diagnosis, please make use of it, especially for the ones that are recurrent, chronic, and despite treatment have not really responded. So I think this would be in a nutshell what the laboratory can support from the point of view of VVs. Thank you.
Yeah, thank you very much, ma'am, for your idea. Now we'll just expect Dr. Meena to just put us on the treatment portion. Yeah. So what generally, basically the signs, symptoms, and summarizingly, when we see of infective causes, basically discharge, odor, itch, and any other associated signs like soreness or superficial dyspareunia, dysuria, all these, and most commonly visible signs like this, all will come with valval edema, edema, as well as fissures and satellite lesions here and there. So basically, with those signs, we can grossly, we can say, but we cannot confirm anything, because white, brownish white, and watery white, it's very difficult to say whether it is mixed infection or it is Candida or it is some other thing, bacterial infection. So instead of going for a blunt, like, okay, this is Candida, and this, if it is thick white, it is Candida, and if it is scanty profuse, then it is typhus. We should always have a clinical background before treating, and always, what rightly Dr. Aruna ma'am, Dr. Ramstein, and Dr. Vaishali has said, always we should have a basic 1 or 2 scores or laboratory test to justify what we are treating. Second, the next slide, ma'am. So basically, vaginal discharge, like whether it is fishy or whether white cuddy, we need to get the pH done, and it's a very easy thing. It's just a strip test, and if you do the strip test, it's very easy, to consider all these things. And if the patient, we can categorize patient less than 4.5, 4 to 5, and beyond 5, like that, we can just think it is less than 4.5 means different group. Then again, we need to reconfirm it, and these are the things. Next slide, ma'am. So now entering after like reaching, see, one more thing before entering into the guidelines. First thing and the foremost thing, as a clinician or as a practicing gynecologist, either in a very high profile town like Dr. Vaishali and like a three-tier city like me, I am practicing in Dhanbad in a very small city. And I am very lucky to have a father who was very dynamic. So he built a hospital in such a way that my OPD is just beside my pathological center, my pathological unit. So I keep on interacting. Doors are same, entrance is same. So, and I being a cytologist, I keep on doing the pap smear, and immediately within 3 days I give the report. One day I take for staining. The next day my report, night I'll be sitting in between my operations. I'll finish up all the pap smear, and then we'll give the reporting, so that we start off with the treatment as early as possible. Whether it is cancer oriented, whether it is high seal or whether low seal or infective. Infective means more, now we need to go into finer details, whether it is bacterial or it is candida, fungal or yeast, whatever it is, we need to go for it. Again, now, next slide, ma'am, sir. Yeah. So I think Dr. Vaishali, ma'am, can you just reiterate what we are seeing now?
Yeah, so as we all know, the bacterial vaginosis, which is one of the commonest cause of vulvovaginal infections, and particularly the recurrent one as well. The recommended regime is metronidazole orally given 500 milligram twice a day for 7 days, or it can be given, it is locally in a form of gel, 0.75%, one full application intravaginally once a day for 5 days, or clindamycin cream, 2%, one same thing, one full application intravaginally at bedtime for 7 days. Alternative to that, may be more patient friendly, tinidazole 2 gram orally once daily for 2 days, or 1 gram orally once daily for 5 days. Sometimes patient may have tinidazole or metronidazole sensitivity. For them, clindamycin 300 milligram orally twice daily for 7 days, or clindamycin ovules 100 milligram intravaginally at bedtime for 3 days. But when we need to inform the patients that ovule uses can tamper the condoms intactness and can give rise to failure of contraception. So next slide, please. For trichomoniosis, the incidence is slightly less, maybe between 5 to 10%, depending on what population you are. The recommended regime is metronidazole 2 gram orally single dose, or tinidazole 2 gram orally single dose. Alternatively, metronidazole 500 milligram orally twice a day for 7 days. And women with HIV infection, where metronidazole 500 milligram twice a day for 7 days. Next slide. Now coming to vulvovaginal candidiasis. As you saw in my first slide, so it is divided into complicated vulvovaginal candidiasis or uncomplicated. The uncomplicated one are the sporadic or infrequent infections, are mild to moderate, or more likely to be from Candida albicans and in non-immunocompromised women, while all the rest come under category complicated, where there is a recurrent vulvovaginal candidiasis. What do you, as Graeme has already mentioned about definition of recurrent vulvovaginal candidiasis, the guidelines say that if a woman has experienced more than 4 episodes of vulvovaginal candidiasis over a period of 12 months, which needs to be ideally proven mycologically, then those are called recurrent vulvovaginal candidiasis. The other one is a severe infection, any infection with non-albicans candidiasis. And another category in complicated is the woman with high risk factors like diabetes, immunocompromised states like HIV infection, or patients who have been on immunosuppressive therapy like corticosteroids. So these all come under complicated vulvovaginal candidiasis. Next slide, please. So the recommended regime are, as we all know, these are OTC, over-the-counter available preparation, and there are prescription only. So OTC, the commonest one available is a local application with clotrimazole 1% cream intravaginally for 7 to 14 days, or 2% cream for 3 days, or miconazole preparation similarly intravaginally either for 7 days, or 4% miconazole cream for 3 days. The oral tablets are equally effective compared to the local treatment as well. So miconazole 100 milligram, so which are the prescription drug? So fluconazole 150 milligram orally single dose. There are the advanced azole preparations, as you can see, ticonazole, buconazole, terconazole. So these are the recommended regimens. Can we have the next slide, please? So coming to the recurrent vulvovaginal candidiasis, which is the most difficult thing, and as Dr. Samir was saying, these are the kind of patient who will make a special journey to see Dr. Samir or to see me in a tertiary center. So the regime is usually to maintain a clinical and mycological control. Some specialists recommend a longer duration of initial therapy, that is 7 to 14 days of topical therapy, or 100 milligram, 150 milligram, or 200 milligram oral dose of fluconazole every third day of total 2 to 3 doses, that is day 1, 4, and 7, to attempt a mycological remission before initiating a maintenance regime. So oral fluconazole may be better suited for for maintenance regime because of convenience and better compliance. So they can 100 milligram, 150 milligram, or 200 milligram weekly dose for 6 months. If this regime is not feasible, then topical treatment can be used intermittently, which may be once a weekly or twice a weekly over next 6 months. So suppressive maintenance therapies are effective in reducing recurrent vulvovaginal candidiasis. Next slide, please. So for severe infection, in severe vulvovaginitis, that is includes extensive vulvar erythema, edema, excoriation, and fissure formation, is associated with lower clinical response rates in patients treated with short courses of topical or oral therapy. So either 7 to 14 days of topical azole or 150 milligram fluconazole in 2 sequential oral doses, like second dose 72 hours after initial dose, is recommended. Particularly in severe VVC, it is also important for us to give patient immediate symptom control because they are so much in pain, inability to walk. So that other symptom control is also very important. Can we go for next slide? So this is the one which is very controversial and non-albicans VVC. So optimal treatment for non-albicans vulvovaginal candidiasis remains unknown. So options include longer duration therapy with 7 to 14 days with a non-fluconazole azole regime, which can be either oral or topical as a first line of treatment. And if recurrence occurs, then 600 milligram of boric acid in gelatin capsule is recommended, administer vaginally once daily for 2 weeks. Next slide, please. So, Dr. Samir, do you want me to carry on, or?
I'll just go ahead with it.
Yeah. Dr. Aruna wants to add a point.
I just want to ask a question to Dr. Joshi and Dr. Sameer. Of contact tracing and treatment in vulvovaginal candidiasis, meaning if you suspect candidiasis and particularly the recurrent one, is there a role of contact tracing the partner?
Generally, we treat both. We don't treat single.
Correct.
Got it.
Okay.
And now in India, we can't ask the woman that do you have any extramarital affairs and all these things. They'll take us to court. So, to save all these things, but indirectly, we ask. Because we give them the option. See, if your husband has got partners, they also should be treated. If you have got a partner, you also ask him to get treated so that you will be happier. Like that, we'll go ahead with.
Okay, thank you. Thank you.
One more thing, but actually, theoretically, candidiasis is not a sexually transmitted disease. But as you know, the use of condom is not much. And so that kind of a sexual practice is not much prevalent in India. But even if they are having multiple sexual partners, unfortunately, and not everybody is circumcised. So I think that is the whole idea of treating the male partner, just to maybe prevent the recurrence because of the hygiene issues and other things. What do you think, Dr. Sameer?
More than hygiene issue, ma'am, like glands, that the membrane of the glands is very sensitive and very thin.
Yeah.
This portion of glands is very thin, and that is why they have got more preponderance for candidal recurrence.
Yeah.
And
Yes.
90% of our females who fail to respond to because of male partners are being untreated.
Yeah. No, that's right. But unfortunately, none of the international guidelines mention this.
That's true.
So, Graeme, can you comment on this, please?
Yes, I certainly can. If the male is responsible, they get clinical candidal balanitis. They get an obviously inflamed foreskin. If there's, and this is probably one of the reasons why circumcision was invented a couple of thousand years ago, because of balanitis. But generally, I agree with you, Vaishali. I do not consider candidiasis a sexually transmitted disease. And in my entire lifetime, I think I can count on the fingers of one hand where there has been a confirmed male origin of the patient's infection. And these males were symptomatic. They either had intertrigo or candidal balanitis. But it's very rare. As I said, I agree with you. I do not consider candidiasis a sexually transmitted infection.
Can I ask one more, Dr. Sameer?
Yeah.
Just, it is something on pap smear. Sometimes you come across candida and it gets reported. These are patients who are asymptomatic. So, do you need to treat it?
We treat it, ma'am. We have to treat it. And what rightly, but I mean, I'm along with Dr. Graeme, I say, see, whenever we are getting recurrent vaginitis and all these things, ideally we should examine the male partners too, because how often we see, being a male gynecologist and female partners, male partners, we don't see. I'm the one to see.
Yeah. No, sir. Because these are the patients who are completely asymptomatic. No, I can understand with a recurrent and things like that, because candida is also part of microbiota of the vagina, isn't it? So if they are asymptomatic, what do you think, Graeme and Dr. Aruna?
If I identify Candida albicans in a patient, I get rid of it because it's potentially so pathogenic.
Okay.
And
for us, if I get a high vaginal swab and there is mixed flora in it, along with some colonies of candida, then we don't report it, because we know that if there's a pathogen, it should predominate. But maybe I should read about what Dr. Graeme has just mentioned and think about it again. potential.
Would it be possible for you to show my last slide that I added yesterday, which sums up my views on non-albicans yeasts? Would it be possible?
Dr. Meena, Mr. Meena, please search last slide.
The last slide that I added yesterday, which sums up my views on non-albicans yeasts and the importance of speciating Candida.
Mr. Rohit, are you there? Or Rohit or Mr. Shailendra? Anybody? Anyway, we are
Yes, sir. Yes, sir. I'm just trying to open it.
just search last slide. What said added yesterday?
NAY is non-albicans yeasts. When the slide comes up.
Till search slide comes up, what I say generally, ma'am, as far as taking the swab, man, our professor, they particularly used to say how to and where to take the swab.
Yes, yeah, very important.
Generally, as a pap smear specimen, I mean, oncologist doing pap smear, we take circumferentially along the cervix. But as far as Candida or this clinical infective cytology is concerned, we should take it from anterior port lip as well as lateral lip, not from the posterior lip. This is a very clear message. I want to share it with everybody. Whenever we are taking a swab, we should take it from the lateral aspect of the vagina as well as from the top portion, not from the bottom portion, because there we'll get more of desquamosate and demorphosed cells.
So I think that was a very important point that you made, because if you don't send a proper sample to, we are naturally going to not report appropriately. So I think that was a very, very important message. So thank you. Thank you so much.
Practice, ma'am, like we are lucky. My father, no, he was a perfectionist like anything. He has pulled
the last slide, thanks.
He was also a gynecologist, sir.
No, there's scroll down. It's 4 slides down. I sent it yesterday. That's not the last slide.
Another 4 slide down, sir. Meena, sir.
That's it. Oh, hold that one for a moment. This was some research I did with Australia's only professor of mycology, and we found that the difference between Candida albicans and non-albicans yeast is that it's only albicans which assimilates glycogen. And that's why the others don't seem to be pathogenic. I'm sorry, scroll down to the last slide. The conclusion slide.
Last one.
Yeah, the one labeled conclusion on non-albicans yeasts.
So this is the last slide which I have, sir.
No, it isn't. Keep going. You can see it on the left, where it's headed conclusion.
One slide below that.
Next one down.
So
one more to go.
So this is what the last.
That's it. That's the one. Yeah. Thank you. I'll say no more.
Okay.
That's it, sir.
I think that's a very important message, Dr.
Yes.
Graeme. Very important message. Thank you.
Thank you.
Thank you.
Okay.
I think we are at the end of our journey of today. And first, I just want to take few questions which is there, and any of us can answer. Treatment for recurrent, what rightly Dr. Vaishali has already discussed. Then, and is there any infection after use of this cream, like Dr. Anusoya from Maharashtra asked? There's nothing. I mean, you can choose either from cream or oral tablets. So it depends upon how and where. And generally, we use mixed type of treatment only. We use both cream as well as oral tablets because they both ask. Basically, one thing we need to understand as far as treating any infection or this yeast or all these things, they are all dependent on immunity. If your vaginal immunity falls, your bodily immunity falls, generally what we see during our fever and all these things, all the ladies, they'll have foul smelling oral as well as vaginal discharge. And this is because when there is a fall in immunity. That is why for our all general mothers, whosoever comes to us, we should always highlight on food and qualitative food, not with those roadside foods and all these things. They can never give us a proper immunity to our system. And most important thing of any fungal, or because fungal and your yeast and all these things, they are proper, they are commensals to our body. Every doctor will accept it. It is a proper commensal, and whenever our body immunity falls, it is that time they grow more and we become vulnerable to the treatment portion. That is why always along with treatment, we should advise them a proper food. Food has to be taken properly, not only during the treatment portion, but post-treatment also, because mother, whosoever comes to us, she is the caretaker of the house and she has to be fit and healthy. And for remaining fit and healthy, we need to advise them a proper nutritional or nutritive diet too, along with medication. With this, I think we will take one or two more questions. When Dr. Nazrul has asked from Bihar, basically before menstrual period, white discharge complaints by patient, please provide some medical advice. Again, it depends upon whether you do just basic tests and confirm it, and always go for a treatment, initial treatment, either with fluconazole, whichever you like, but get a testing done, confirm it and test it. Again, we see large number of questions. 22, first trimester pregnancy, what is the best treatment for candida? Dr. Aruna, you want to address it? Dr. Vaishali?
I think irrespective of whichever trimester in pregnancy, the guidelines international says is topical antifungal is the treatment. So, but it has to be given for 7 days. So that is very important.
One more thing, ma'am, like first trimester, generally we try to avoid as much as possible. We'll allow them to do, but after first trimester, we can allow them with any topical medicine, because if not first trimester, at least for first 6 weeks, we should try to avoid any medications as far as growing child like in the utero is concerned.
Yes, sir, that's okay. But I think international guidelines say topical should be okay in, throughout the pregnancy. So if the woman is really suffering from it, then I think I would give her.
Absolutely.
Sir, yeah. Sir, can I just, since you're on this, can I just put in few points across? So there has been things about the probiotic treatment, and people go right up to the extent putting yogurt in the vagina and all those things. So those are the extremes. But I think, as you said rightly, the diet is very important, and to get that balance in the these natural orifices is important. So probiotic, though they haven't shown much of help, but they may just help to get back that ecosystem in control. The other things are also, I want to make a point, even you must have come across, there are lot of ladies who maybe culturally we think even a healthy discharge, they have that something deep ingrained in their mind that they have been having chronic leukorrhea or vaginitis. So that also we need to educate the woman that it not always is an infective pathology, because it is a body's response to the hormones. So that education and treating unnecessarily OTCs, that can give rise to recurrent vaginitis, mixed infection. It is like a, I would say, vicious cycle which we need to break, and that itself will allow the ecosystem balance in the vagina.
Thank you very much, madam. One more thing, ma'am, like I had been working in very island countries. There I've learned one thing, and right now in Dhanbad also, I just advise all my female patients, at least once a week, with lukewarm saline water, clean your vagina, vulva. I've never seen even one patient in in island countries like Maldives or Mauritius, patient coming to us so frequently with vulval infections and vaginal infections. I've never seen.
Yes, sir. And the other thing, women have that they feel dirty because of a healthy discharge, and this practice of douching, that also is one of the commonest cause of bacterial vaginosis. And the simple habits of washing front to back. So even if you tell patients these things, simple thing that itself take care of their local skin issues like a dryness, overuse of medicated vaginal washes and things like that. So that itself can trigger the vicious cycle of scratching, irritation, unnecessary antibiotics, antifungal. So even that kind of a message as a public health initiative, if we gynecologists give, that will really help a lot of women in our country.
I tell them to take sitz bath once a week, each and every, starting from the moment the girl attends menstrual menarche. I tell them once a week, take sitz bath with saline water. Simple. Don't waste much time coming to doctors. We tell them, see, our hospital, our OPDs are flooded with all these things. Cut short all these things. They are very happy. Now, everybody, once in a week they do, and they say, we are fine off, sir. Thank you very much. So
Okay.
we'll just want to thank, I just want to thank Dr. Pujari. Even though she is ill, we can see by his face, but still she has obliged us by sharing his important vision as well as application towards this field. And I want to thank Dr. Vaishali also. And she has given us so many insights, and this is how we grow. And I wish again we'll request FDC again to give us another platform to be again with some other topic also, so that we can share so nicely so many things. And at last, I like to thank Dr. Graeme Dennerstein to highlight us with so many important inputs. And with this, I think we'll ask Dr. Meena to just go ahead with it. Mr. Meena.
Yes, sir. Thank you, sir. Thank you, sir. I would say that is the most wonderful session I have heard, and I'm sure audience may have the same feeling. Just to give a vote of thanks, I would like to thank Dr. Graeme Dennerstein first for sharing not knowledge, wisdom which he has acquired in his vast career with research and practice. Thanks a lot, sir, for highlighting the role of fluconazole in the management of VVC and telling us the right dosage and duration of fluconazole, which is very important for better management. I would like to thank Dr. Sameer Hazra also for beautifully moderating the session and highlighting the important point of the discussion. Thanks a lot for Dr. Vaishali for sharing the practical points in the management and treatment. That was very beautiful, and I'm sure all the audience would take them with them, take those points with them. Most importantly, thank you, Dr. Aruna, for telling the audience with proper diagnostic techniques, which we really require in Indian scenario, and what we can do ourselves and when to refer to a proper microbiologist and diagnosis lab. So thanks a lot for that. I'll thank all the panelists, and I'll thank all the audience for taking out time on this Sunday morning and joining us for this session. And lastly, I would like to thank the technical team for beautifully conducting this session without any technical glitch. Thanks a lot, everyone.
Thank you.
Thank you.
Thank you. Thank you for having me.
Thank you, sir. Thank you.
Bye. Bye.